Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Shada. I would like to thank the organizing committee of this conference and to thank my dear friend, Dr. Wiam, for inviting me. This is the fourth time I present in this very excellent conference. I'll take you away from diabetes. I'll take you to a different atmosphere and especially the atmosphere related to reproductive endocrinology. This is a pointer. Sorry. This is a breakthrough in reproductive endocrinology, and it was announced just a few days back. Professor Melina, who is a scientist at Max Planck Institute in Berlin, have announced that now we can rejuvenate eggs. That's a tremendous work that will change the whole ideas and principles of reproductive endocrinology, especially for aged women. Now we have discovered the protein which is called Shengshun-1, a protein that make the chromosomes of the aging oocytes, aging eggs, unstable and make the chromosomal abnormalities for women who are passing the age of 35, 38, 40, and so on. Now we have discovered that this protein is making the chromosomes unstable and make the chromosomal abnormalities. Her group injected micro amounts of this protein to the eggs, as you see in the middle picture. And with the injection of this, we could rejuvenate the oocytes, and we have succeeded to lower the percentage of abnormal eggs from 71% to 40%. The progress in this field will make the primary ovarian insufficiency applicable for future reproduction and improve the outcome as well. I'll talk on these aspects as mentioned here in the content, and I will start with this picture. During fetal life, around the mid-pregnancy, the female baby will have something like 20 to 28 million primordial follicles or future eggs. At the time of birth, this will drop down to 1 million in each ovary. And at time of first menarche, it will be 350,000 in each ovary. And during her reproductive life, the female will produce to us between 400 to 600 maximum number of mature eggs. And once these eggs are fertilized, they are potential human beings. The human beings are bad example of fertility, very bad example. Who needs all these millions? Who needs all these thousands? This is on the female side. And the male side, it's as well. Male produces 1,000 sperm each second. And that tells you how bad we are as a species for reproduction. But still, we try to survive by having the large number of these eggs and sperms. After the age of 50, 51, which is supposed to be the menopausal stage, there are at least 50 to 60,000 dormant eggs that can be rejuvenized. That's why I started my talk with rejuvenation of the eggs. That's truly a breakthrough. And when we talk about the follicles, the antral follicles, I want you to focus. That's how they look like when we do ultrasound in the ovaries, like a black circle. Of course, with age, those numbers decline, and at the end, they go to apoptosis. The first one to describe primary ovarian insufficiency was Fuller Albert in 1942. He described a syndrome of amenorrhea, estrogen deficiency, menopausal FSH levels, and short stature. And this he coined to differentiate it from the pituitary type or the secondary ovarian insufficiency. And that was the first written report. And that's the article published by Fuller. But in history, the Chinese, you can find in their literature in Qing dynasty that one of their physicians have described what happened to a lady, and it translates not yet old, menstrual water cut off. So she is not yet in menopause. But the modern definition has passed through different stages. In 1939, Hiller and Hiller described what's called hypergonadotropic hypoestrogenism, and Atria in 1950 described and discussed the clinical features of this type of presentation in 20 women, and later Demoras and Jones defined as what is called non-physiological amenorrhea before age of 40. That is a look back, and if we go to PubMed, as what Cooper has done in 2010, he found that what is described as primary ovarian insufficiency has also many other names, including gonadal dysgenesis, premature ovarian failure, and all other names. So how common is this? Globally, it's 1% for women who are less than 40. 1 in 1,000 for women who are less than 30. 1 in 10,000 for women who are less than 20. And this is multifactorial etiology, I mean globally, including the autoimmune, the genetic, and the iatrogenic causes. While in the Arab world, there is higher genetic contribution, and that is referred to consanguinity as a linked risk, which is increased in the Arab world. In the GCC, there are no definite studies, but it's more linked to genetic clustering, especially the mutations NOPOX and BMP15. This is only on clinical-based studies. The risk, of course, increases with age, becoming more common between the age of 35 to 40. How does this happen? There is follicular depletion or follicular dysfunction, one of these two. But the most common is follicular depletion, and that can happen by reducing the number, accelerating atresia, and active destruction. The accelerated atresia and destruction most of the time is iatrogenic, like what happen in chemotherapy and radiotherapy, while the follicular dysfunction depends on the enzymatic disturbance and the receptors for FSH mutations. But by and large, the idiopathic is the most common. There is no definite cause for the idiopathic. For the iatrogenic, it's the toxins like chemotherapy, radiotherapy, even surgery, even hysterectomy sometimes can cause that. But the worst is what we are seeing now is smoking. I'll talk about it later. I'll show you. The genetic and the chromosomal problem, the most common, and we should remember it all the time for those who are having primary ovarian insufficiency, is the what's called Fragile X syndrome. The Fragile X syndrome, there is a mutation, and we should catch those cases in pre-mutation stage. The mutation is FMR1 pro-mutation that will help us detecting those cases and preserve their fertility later on. Also, Turner syndrome is another one. And the autoimmune, which is antibodies to thyroid, antibodies to ovaries, antibodies to the adrenals as well. In the last week, I had few patients between the age of 30 to 40. And the first thing they come with menstrual disturbance, they come and ask me, am I menopausal now, doctor? Now everybody is obsessed with this, I'm menopausal or not. Of course, they try to get an answer quickly. So I tell them, so what's your complaint? If they mention any of these presentations or complaints, I start talking to them about menopause. They try sometimes to be smart. I have read what's in ChatGPT Medical, and what I have goes with premenopause, with menopause. I tell them, just tell me what's wrong with you. I will tell you if you are classified as that. All these symptoms should be there to classify the patients. How we assess them? If you suspect, you should do the following investigations, especially the hormone profile, the autoimmune, the antibodies, karyotyping, DEXA, and always do the ultrasound. If you remember, I told you about the antral follicles to see if the ovary is having antral follicles. They are not by any means menopausal. The last one is the anti-Mullerian hormone. And this is the disastrous hormone, I call it, because every woman is coming to me with the result of anti-Mullerian hormone and started arguing with me that I am menopausal. I have AMH in my hand, which is almost zero. 2 months back, I watched in the media a brilliant Lebanese gynecologist who had one of his patients with AMH. He showed us that the AMH is 0.001, and she had 3 spontaneous pregnancies and deliveries. 3 with AMH, which is almost zero. So AMH is to tell you about something. but it is not equivalent to menopausal at all. We have to check on the patients who are having primary ovarian insufficiency to know their AMH, but that does not mean that they are not going to conceive. So how is the clinical pathway to diagnose it? We have to do 2 readings at least for FSH. Some say more than 25, some say more than 30 international units per liter on 2 different occasions, at least 4 weeks apart, at least, with symptoms of menstrual irregularities. Of course, suspicion is very important. You should be suspicious about this. It's iatrogenic. You should ask, have they been exposed to chemotherapy, to radiotherapy, or whatever? You should investigate the genetics, do the karyotyping, and sometimes we do what's called whole exome sequencing, looking for the whole exome. Of course, the autoimmune, we have to look for the antibodies. I will go a bit faster because I want to show you what's important at the end. Of course, if we do not find any of the above diagnoses, it's idiopathic. This is a group of mutations for premature ovarian failure, and you can find the locus of those mutations there, and it is very well known. This mutation, FMR1, is very important because it tells us about the Fragile X syndrome. And with the Fragile X syndrome, patients can have premature ovarian failure and as well tremor ataxia syndrome. And if we catch them early, of course, you have to also screen the family. I have one family who, the three patients who are having, the 3 of them have Fragile X syndrome. They married, the one who married younger had 3 children. The other 2, unfortunately, we couldn't do anything for them. At that stage, we did not have ovarian tissue or egg freezing available. So if we catch them at the pre-mutation, this test will help them, and we can do oocyte freezing, or we can do ovarian tissue freezing for them. The long-term sequelae of the primary ovarian insufficiency, these are the complications: osteoporosis, cardiovascular disease, depression, and others. Okay. When they were interviewed, those patients, 71% of those said they are unhappy by the way their doctors have told them about their condition. So they were devastated, shocked, and confused. Mind you, 5 to 10% of those patients will spontaneously conceive. So don't tell them that they are having no fertility potentials. Of course, these are some examples of what they are telling you when they are first told that they have primary ovarian insufficiency, and all were bad. This is how the normal ovary behaves and the primary ovarian insufficiency ovary behave. And if we look at this chart, this is how the genetic involvement, all those blue genes numbers and loci tells us about the potential of those cases to have premature ovarian insufficiency. And of course, at the end down there, there are 2 mutations, MCM8 and MCM9. Those are the most important mutations. And once there is crossover, the patient will start having the symptomatology clear. Smoking, especially what we are seeing now, this bad vape. Vape is a disaster equivalent to radio and chemotherapy to me. Men or women? To women. Let's focus on women. The polycyclic aromatic hydrocarbons induce the expression of BAX, which is pro-apoptosis gene, and this will cause oocyte destruction, apoptosis, and of course, eventually, irreversible type of ovarian failure. If you look at the graphics there, the smokers will have pre-menopause, menopause earlier than the non-smokers. Practical. If a patient presents, what would we do for them? Hormonal therapy. We prefer the transdermal estradiol. It's available in Bahrain as well with the same dose. This is 100 microgram per day. There is also the compounding pharmacy, which is in, I think, Muharraq. You can ask them, they will get you the same concentration. It's the most physiological, the transdermal, and it avoids the bypassing it bypasses the hepatic first pass metabolism. So no gastrointestinal side effects. We can use the estrogen, estradiol valerate, 1 or 2 milligram, depending on the situation and the symptoms of the patient. And if the patient is having a uterus, we should add progesterone to make sure that the patient is cycling. Don't give estrogen alone. Estrogen alone is not the treatment, especially, again, if the woman is having a uterus. You can choose Nutrogestan, you can choose Cyclogest, you can choose Dufastone, whatever progesterone you are giving to them, give them 10 days at least, twice a day. That would be fantastic. If a patient is very young, in the teenager group, she had no menses or she had menses once or twice, what do? We build up the estrogen gradually.
Doctor, we have less than 2 minutes.
2 minutes?
Yeah.
Okay, we built up, we add to that progesterone within 6 months, and then you can add androgens, and to avoid all this, to avoid osteoporosis. DHEA is of value, dihydroepiandrosterone sulfate. This is a proof. DHEA lowers the FSH level for those patients, and they can conceive. Growth hormone as well is of value, and this is the proof, the meta-analysis. This is the example how we should do and handle the complications. I want to go a bit faster to tell you about the new horizon, what we are doing now, estrogen pro-treatment for those cases, ovarian tissue cryopreservation, and ovarian activation. We can activate primordial follicle by treatment with, we can do laparoscopy, take the tissue out, cryopreserve it, activate it, and put it back, and then stimulate it. Or without it, without passing through the in vitro activation. This is how we do it. We take by laparoscopy some tissue, activate it. This is in our lab. We take tissue, we fragment it, we put it into slices, then we freeze it. If the patient is married, we do stimulation and keep the eggs, like what's there, transvaginal. If she is virgin, we do it by laparoscopy. That's also our work. Very few can do the transabdominal laparoscopic aspiration, or we can. Give me one more minute. Okay, thank you. Okay, this is how we transfer, we put back the tissue. Once we stimulate, we can get the eggs, fertilize them. This is in vitro activation of the oocytes. This is the scheme how we do it. In 2008, the American Society was considering ovarian tissue and oocyte cryopreservation as investigational. In 2014, it became none. It should not, should no longer be considered experimental. These are the chemotherapies that affect how we should integrate the model of care for the patients. And this is the breakthrough, how we can make eggs from the stem cells, mesenchymal stem cells, bone marrow mesenchymal stem cells can end up with ovarian tissue, and how to avoid the damage of the oocytes and the eggs so that the patient can keep with the hormones.
And that's 1 minute over.
Yeah, thank you very much. And I have finished.
I'm not sure if we have time for the questions. Can we take? Yeah, we can take a quick question. If I may add or comment, Dr. Jibril, ovarian insufficiency is, people see it as early menopause, as
Yes.
you said. So the treatment always, unfortunately, is always diagnosed very late, the ovarian insufficiency. Yeah. And but the primary treatment for them is mostly hormonal replacement. So what do you think the approach should be to avoid such late diagnosis?
The idea for those patients is to have, they should be handled by the endocrinologist, the reproductive endocrinologist, the psychiatrist, and the primary health care.
Holistic.
Holistic type of approach. And please, if you find any patient with primary ovarian insufficiency, please start them on HRT. Forget about this. HRT is going to cause cancer. This is nonsense, because if you keep them vital, their ovaries and their uterus, they have a chance. They have a chance, especially if they are autoimmune, for example. They still have eggs in their ovaries, which they can conceive later on. I can. Okay, thank you.
Thank you very much, Dr. Jibril. Any questions?